Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Well, Shane, we had a great conversation with Chris Wyatt last time, and we're happy to have him back again, as well as Dr. Jeremy Sturgell.
Yeah, it's great. I'm just delighted to have Chris Wyatt back with us, as well as Dr. Jeremy Sturgell, medical director out of the Barton County Emergency Department, and excited to have him on our podcast today to share his side of the story. And welcome our audience to part two, real-world success in telehospitalist care in the rural environment. And we're just excited about this episode today. It's really going to be a great addition to part one, which incidentally, if you haven't heard part one, you need to go back and listen to part one, which was the full discussion with Chris Wyatt. CEO is also with us today. And you're missing out if you hadn't had a chance to go back and look at that. Listen to it.
Yeah, we had a great conversation at the Missouri Hospital Association, and it's definitely worth listening to.
For sure. Well, hey, without further ado, would love to introduce Dr. Jeremy Sturgell. Dr. Sturgell, would you mind introducing yourself and sharing us a little bit about you?
Yeah, no problem. Hey, thanks for having me. Thanks for coming, Chris. Excited to be here. So I am Dr. Sturgell. So I actually grew up here in Barton County. I graduated from Liberal High School, which is a town probably about 15 to 20 minutes west of Lamar, town of 700. My wife is from here in Lamar, so we're local. We're hometown people. I did my undergraduate in Joplin, Missouri, which is probably about 40 miles down the road just south of us, medical school at the University of Missouri, Columbia, and I did my residency in emergency medicine in the University of Illinois, and I graduated in 2010 and came back here in 2010 as a director, and I've been the director here at the emergency department at Cox Barton for going on 15 years. I joke with everybody that's too long to be the boss of anything, unfortunately. But through my time here, I've wore many different hats. I'm currently president of the medical staff. I'm also our stroke medical director, our EMS director. I do quite a bit of things here, and maybe we can touch on that later in the conversation, just the amount of hats that you have to wear and roles that you have to fulfill being in rural America and how that relates to our discussion today.
Yeah. I got to tell you, after hearing that introduction, that just absolutely fits our wheelhouse and passion about rural medicine. And Dr. Sturgell is really an icon in that sense, based on that introduction. So that's fantastic, fantastic introduction. And we also have Chris Wyatt, who was with us last episode in part one. Chris, maybe just a quick introduction for yourself as well.
Yes, Chris Wyatt, president of Cox Health at Barton County. I've been here at this hospital now 5 years. And I'm originally from Missouri, but made my career in rural America. And, Dr. Sturgell is exactly what we look for as a CEO or president of a hospital in rural America. That one provider that really wants to take the reins and is passionate about the community, wants it to grow. Then we can just step aside and let them do what they need to do and support them, whether it be for financial endeavors or just through the support structure that's built around them to do it. So it's been great to be able to have that partnership, and especially with you, Shane, and with Brian Health coming in to support our telehospital services. It just came together at the perfect time.
Yeah. Well, I appreciate that, and appreciate your time again. Exceedingly grateful, Chris, for your time for our last podcast in part one, and I appreciate you taking time out of your day to be with us here in part two. So let's get started. And why we're here today is really to dovetail into the conversation that we had in part one from more of an administrative perspective on how a telehospitalist program can really benefit a rural hospital. And today we're going to shift gears a little bit into more of a physician's perspective and a local physician's perspective. In this case, happens to be emergency department, which, as everybody knows, is essentially the front door of any organization, the hospital business. So excited to have Dr. Sturgell here today. And Dr. Sturgell, I thought we'd start off with, when we first got involved in this program, we shared a little bit of this insight last episode. was really started with working with administration, system administration as part of this project and the concept design around this project. And one of the things we always look for early on in this is a physician champion and one to help sort of drive this and drive the concept and drive that locally. And holy cow, Dr. Sturgell was the man when it came to that. And so I'm interested in your thoughts, Dr. Sturgell, when we started talking about the concept in general and talking with administration, system administration, and then a critical access hospital within that network. Can you kind of shed some light on your perspective and maybe what your reaction was when the concept of Telehospitalist came up?
Yeah, so I think I'd like to back up and just kind of explain where we were at and how we've developed over the last decade. So 2018, we affiliated with Cox Health, but prior to that, we were an independent hospital, county-owned hospital, and we were really in the old paradigm, right? So we were that place where we had a cadre of 6 primary care physicians that practiced medicine the old way, right? They rounded on their patients in the hospital in the morning. Then they went to their clinic, saw their clinic patients all day, fielded calls all day, came in the afternoon, rounded on their patients at night, and then went home and took calls from the ER at night. And, wash, rinse, repeat for 30 years. I mean, that's what we were doing here. And that's how medicine used to be. And we were a pretty late holdout to that. But it was probably the year before 2018, we started to realize that a change was coming. That way was not going to be sustainable in the future. It's very rare that you find anybody that comes out of medicine anymore that wants to do that wants that life, that wants the full complement of, say, family medicine or primary care, where you have your foot dipped in kind of everything, both hospital work and primary care and the clinic and everything else. So we knew that we were getting to a critical point. We had some older providers that were retiring, and we're like, what are we going to do? What's the future going to look like? Because what was in front of us was not sustainable. It's very, very hard to get people to come to rural America. And we thought that, well, maybe we could have success recruiting a hospitalist, but then what are we going to do? We can't work somebody 24/7, 365. So the reality is, to build a program to cover our needs, we were looking at probably 4 providers, 7 on, 7 off, days, nights. And that was probably too heavy of a lift, especially at the time as an independent hospital. So we were at a change point. We were at a threshold where we had to decide what the future was going to look like. And throughout my time here, I've always kind of had my feet in different places. I've always kind of on the side been a locums provider and worked part-time at some larger places, larger trauma centers, smaller places. And a lot of that too was to find out what people were doing and get a lay of the land. And I'd had some experience with Telehospitalist as a concept at some of the other places. And so in my mind, I was an early adopter, but we were never in a position as an independent hospital to have the resources to pursue something like that. So really, when 2018 came around and we affiliated with Cox Health, that saved this hospital. Okay. Kept us afloat, gave us the resources we need. So that was sort of the first step in being able to sort of bring alive these changes that we needed to have happen here. And I think, Chris, you came about, was it 2018? You came kind of right around that change period, right?
I came 11 months later. So Cox Health acquired in January, end of January of 19, and then I started the end of January 18, Cox Health, and then I came January 19.
Yeah, so when Chris came on, I believe that there was already some nascent discussion over this program.
Right.
We have some people in this organization I'm very thankful for. We have some visionary leaders, some very forward-thinking leaders. Max Buteau, one at the time, he was now CEO of the whole system. He was not in that role in 2018, but it was very evident that he was a very forward-thinking administrator. Darren Bass, Chris. So a lot of these things were in motion when Chris came on board. And this is all, remember, this is all pre-pandemic. So I can only imagine if we we were trying to do this maybe a year later, the challenges that would have entailed. But we knew that this was going to happen just from a survival perspective. And so I think that is sort of the background as to why in 2018, 2019, that we were really at a point that we needed to make a decision on what the future was going to look like.
Sure. And so you come to the conclusion you needed to make a decision, and you needed to sort of shift that legacy model, that you needed a paradigm shift. And that's when they engaged Teledyne out of the gate on that front to have some of those conversations. But in terms of the discussions with administration and when the telehospitalist model was thrown out there on the table, what was your initial reaction? And as you further vetted that model and that concept, what were you hearing from maybe the local providers or the emergency department providers or the nursing staff?
Well, as I mentioned, I'd had a little bit of experience, and I'd seen places that pulled it off successfully with various different vendors and services. So I knew it was a viable option, and if it was done well and done right, it would be successful. But this was something really, really foreign to the people in this building, and everybody's afraid of change. So one of my first thoughts was, man, I'm going to have to do a lot of legwork myself, Chris, some of the other leaders, and getting out there and explaining the process, explaining the vision, convincing people of the vision, convincing people that this is where we need to go, and kind of overcoming, the trepidation and those barriers to change. I think I was the only ER provider actually that had worked at a place that had used teleservices, and I know from my providers in the ED there was a lot of skepticism. There was
Sure.
a lot of fear that this was going to be subpar, was going to be unsuccessful. The technology issues we're in a rural county, right? So obviously internet service at the time was it's always a question mark. So there was just all these issues and a lot of naysaying about all these different things that could go wrong. And so I think that was one of our biggest challenges was getting people on board with the vision and convincing them that this could work.
Sure. And that's such a huge value add to trying to get this type of fundamental change implemented is you got to have somebody willing to go out on the front edge of this and lead it, right? You need administration, and Chris was excellent on that front and helping to push this and lead this out. And then you have yourself really the main physician champion because – and I've said this before, I can't think of any hospitalist program that we've launched over the years where we've had 100% med staff buy-in out of the gate. There's always skepticism. Yeah. There's always
somebody who's concerned about all of the things Dr. Sturgell just mentioned.
Yeah, the 4,000 what ifs they start to pile up pretty quickly. But having Dr. Sturgell as leading that out was a key piece in terms of the physician champion.
Absolutely.
And now that, I remember Dr. Sturgell in some of those early days and before the program started and before the program launched, and just chatting with you. And it's one of those, you come to the point of realization, I've been championing this thing for so long and over the last 90 days, 120 days plus, and now we're coming close to go live. And then you kind of hit this moment, you're going, well, I hope it works. I hope it works. I hope we didn't just, because I kind of put my name on the line on this, right? You put the name on the line, and it's and you got all these naysayers just waiting to pounce, right? They're just waiting to jump on the first issue. And I remember the first consult that we did, and Dr. Sturgell went out of the emergency department, went down the hallway, and was standing in the doorway, just watching, just sort of seeing. Hey, okay, I'm going to see how this goes, just to make sure. Can you maybe give some perspective on that from how you were feeling and then just watching the first consult and as the program got off the ground?
Oh, yeah. No, for all those reasons. It's like, we had myself and Chris, we had a lot of skin in the game. We needed this to work. And I think, one of my first thoughts was, man, I hope the towers hold up today. I hope our internet is really good.
Yeah.
But I tell you, what I was, and I mean this, what I was happy to witness is that moment was a milestone for this hospital.
Yeah.
That was a moment where we stepped into a new way. Okay,
Right.
we stepped into what I believe is going to be the way going forward, and so I remember distinctly having that thought was like, so it begins. You know, we're here,
Yeah.
and it went off smooth. It was a great consult. The novelty of that first consult was pretty special to watch with all the staff and the providers, and we've just hit the ground running since that time. It's been quite something.
That's great, and it's got to be satisfying to see that go through with, as you mentioned, the skin in the game that you and Chris had going into this program. There's a lot riding on this, and boy, the initial consults, those first handful of consults out of the gate are so critical, and it was. Thankfully, yeah, all those towers held up,
Yeah.
and the excavators weren't digging up the wrong lines at that point in time of the day.
No
So
doubt.
that's spectacular. So the program's matured significantly since 2018. And can you maybe speak to your experience and over time, what your experience has been in the emergency department and your emergency department team and the providers and what their sense of the program is and how the relationships that they've built with the hospitalist team and overall, how has that affected the ED practice with things like throughput and volumes? You know, Chris and I talked about impact on the ED volumes in part one. So again, go back and listen to part one. It was great. But what's your perspective on that?
Oh yeah, we could. You know, there's a lot to say on this. I think the first thing I'll say is, you know, that initial sense of trepidation and change resistance. What's funny now is we've been doing this now for several years. Now that is the established way, and I mean, if I had come to my providers today and say, hey, we're not going to be doing, you know, Telehospitalist at night. I mean, what? So now that's the established paradigm, and so it's kind of funny to see that. But yeah, no, things have been incredible in terms of our journey as a hospital from the ER. Our mission, of course, you know, our system has a wider mission, but we also kind of have a local mission, and sometimes it's spoken and sometimes it's unspoken. But we have an obligation and a deep desire to care for our patients in this community locally as much as we can, and that's really always driven a lot of our decisions and a lot of the way that we look at things here, and that's even inside of the larger mission of Cox Health. But over the years, out of the ER, since we've affiliated with Cox Health, our volumes have grown. Every year we see growth. Every year we've been seeing growth in admissions. So we've been able to, over the last 5 years since Chris has been here, we've been able to keep more patients locally, and those are real numbers and very, very impressive numbers if you were to look at the trends.
So Dr. Sturgell, you've given some insight on your providers' feedback and potential burnout. As you you talk through your provider satisfaction and relationship with the hospitalist, what about some metrics or numbers that you're seeing out of the emergency department? I know that in part one of the podcast, we talked about the impact on the ED as an overall perspective in terms of percentages. But from your perspective, what have you seen in the emergency department in terms of volumes over the years since we started the program?
Well, I mean, it's been a resounding success. I mean, I can give you some exact numbers. So in 2018, when we affiliated with Cox, right at the start of this project, so we had about 380 admissions a year from the ER to our hospital. And on the other end, we were transferring out probably about 450 patients. So fast forward to this year, so last year we did 750 admissions to our hospital, and we had those transfers down into the 330s. So we have made significant progress in flipping the script. We've almost doubled the amount of admissions that we've been able to keep here. So I think that it's been a resounding success.
Yeah, and that's amazing considering the sheer volume has increased. I think that in part one is somewhere between 25 to 30% in terms of the increase in volume. So to see not only that kind of increase in volumes, but a inverse relationship to transfers is really phenomenal.
Yeah, that's
awesome.
incredible.
Yeah, so I think that's the thing that may get missed too, and I have to remind people we've had that increase in volume, but even within that volume, we've had even a higher increase in admissions and admissions and cut out the transfers, but that still counts for acuity. So that volume of patients is a cohort of sicker patients, and we've been able to keep those here.
Absolutely.
And avoid those transfers.
Yeah.
Yep.
No, can't agree more. Can't agree more. And again, by the way, those 750, or at least those based on the volumes, probably you were looking at somewhere around 600 transfers or thereabouts, had things been the same. Those 300 patients were thanking you big time.
Yep.
So,
Yeah, absolutely.
Yeah, that's amazing.
And that just makes it so much easier to recruit. When you have the volumes that are there, nurses are happier when they're busy and they're not sitting around. The
Right.
patients are happier. And then the transfers are decreasing as a percentage because of the fact that now all the ambulance services in the area know that when they come to our ER, they aren't just going to be band-aided and sent out.
Right.
Our ER doctors have confidence that now I know I can admit them, and it just trickles from there to where you start getting more ambulance traffic because everyone else around you is, shipping them out to the tertiary center. So it's just been absolutely amazing.
Yep.
Chris, that's a great point. I'd like to jump in on the end of that. But ambulance diversion over the years here has been a problem, and that has been a real issue that has been fixed. The other issue too is just patient diversion in terms of the in sort of their own mind, right? So if you have a family member that comes to the ER and it's like, and then everybody gets on Facebook and social media, well, grandma came in with this and this, and they're having to send her to Joplin or having to send her to Springfield. Well, I think that resonates with people and it sticks in their mind, and subconsciously it creates this image that, well, you can come to our rural hospital, but they're ultimately going to have to send you somewhere else. So you might as well just go there to start, And I think that we've been able to reverse that and over the years, and now it feels like this is a first destination for people.
That's a great turnaround.
Yeah, that's spectacular, and we kind of dove into that. Chris and I did in part one. So go back and check that out. But it's some amazing numbers here, and again, kudos to the amazing work you guys are doing in Cox Barton County.
Teledyne, Brian Health, they've been a large part of that for many different reasons. Foremost of which, as I mentioned, we were on the ropes in 2018. If we wouldn't have affiliated, if we wouldn't have made this change to go to this model, I don't know if we would still have an inpatient service. And Chris, I don't know if I'm maybe being hyperbolic, but I really think that was a threat. Would you agree with that?
I agree 100%.
And figure out something until we get to 2. And that, for one, allowed us to get our feet off the ground and start running right away. And that gave us some time to build the program to where we're at now. We have 2 full-time hospitalists right now, so we basically have week on and week off, they alternate. And then at night, we use, Brian for our night admissions. And we also have a nurse practitioner that helps as well. And what that does is that allows those providers to come in every day, to be fresh, to focus on their 12 hours at hand and give all that they can, knowing that they're going to go home and they're going to have time for their family, time to decompress, time to get the rest they need to come in the next day and be ready to deliver excellent care. And so that's one point. The second point is the quality issue. I don't know if we had mentioned that or not, or if you wanted me to touch on that, but I think
Absolutely.
It's pretty important.
Yeah. Mm-hmm.
So we have several major quality initiatives at our hospital at Cox Barton. Initiatives we feel very passionate about. The foremost of which is our stroke program. I'm our stroke medical director. We started that program in 2019, so shortly after Chris got here. So you can imagine we had a lot of activity in this building going on at a very small period of time. So a lot of moving parts. But we have built. We're a level 3 stroke program right now in Missouri. When we were actually certified by the state, they came in and were so impressed with how we did things and say, well, your program is almost functioning as a level 2, and we we were very, very proud of that. So we have a big emphasis on neurology here. We have a big emphasis on stroke. And one of the things we looked at over the years was we were sending out a lot of stroke patients. Okay, they come into the ER. We didn't have the services to support that, so they would get sent out. And that was a low hanging fruit. And if there was a way that we could keep those patients here, that would be a success for the hospital. And I'll come back to that in a minute because I want to tie that into something. But as it relates to Brian, we have a lot of quality metrics with that program. Okay, a lot of very, very strict quality metrics, and with Teledyne Brian covering probably close to 50% of our admissions, boy, they have a large stake in that. They have a large responsibility and a large stake in our quality metrics. And I tell you, we continue to excel. We've seen there's not anything that we admit over the night that comes in that we are just not on the ball. We have not had fallouts from that regard. In my role as a stroke medical director, I overlook that. So when we hand those patients off to that night service, they may not practice at a level 1 stroke center or level 2 or level 3 stroke center, but they have met everything that we've asked of them. And so the success of that program, they have a share in that. And I'm very, very thankful for that as well. So that's the first example. The second example would be sepsis. So our system as a whole, several years ago, identified sepsis as a very, very important quality metric, a major area for improvement. It's a major system initiative right now, major rollout, major focus on sepsis. And again, this hospital, so I'm happy to report that this month was the first month that the system had abstracted our charts for analysis, and we are leading the system in SEP1 compliance, which, if you know anything about SEP1 and CMS and sepsis, you know that it's probably the most onerous and difficult quality metric that CMS has ever published. There's potentially 7 metrics, and if you fall out on one, you fall out on every metric. And even the best performing hospitals, I think it's maybe 50%, 60% or so, and we're at 77% compliance right now with SEP1.
That's excellent.
And again, Brian has a lot of ownership of that, because we'll admit these patients at night, and there are metrics that have to be completed on the floor. So there's things that become the responsibility of that night hospitalist, and they just get done, and they're done. And like I said, we're leading our system right now in compliance with SEP1, and a lot of that is due to the work that they do and the work that they continue to do at night for us.
That's fantastic. And again, I've seen all the quality metrics and numbers. I know, talking with Chris early on in the program, when we were discussing the launch of the program, and you as well, Dr. Sturgell, one of the concerns was, of course, just the overall, all the what ifs, right? The technology failures, et cetera. But quality is a big component. Will the quality maintain? Will it exceed? Will it continue to elevate the level of care in our facility and or maintain that? Or are we going to see a nosedive in quality? And obviously, based on the numbers we've seen, fantastic results on that front. What about, you mentioned your ED providers. How about the local primary care base? And what are you hearing from the physician side of the equation as the president of the medical staff, as the local primary care physicians chat with you in and out over the last several years as part of this program? What do you hear from them in general? And then how about patients that come to the ED that you've actually seen before and have been admitted previously by the hospitalist program, and do you get pushback from patients that have been previously seen by one of the telehospitalists coming out of the ED? So it's kind of a two-part question. What do you think of both those fronts?
Well, I think that in terms of the patients, I can tell you right now that I can maybe count on one hand, since we started the program, where we've had a patient that's been displeased that they've had a teleconsultation. And that's not only for the telehospice program, that's for the telestroke program as well. And I think that speaks to the probably the overall acceptance of this technology in the lay public. I think the pandemic did a lot to speed that along and sort of reset societal expectations. But I tell you, I've been the medical staff president for years now, for too long. I'd like to jettison that off to somebody else one of these days.
Yeah.
But I cannot recall a single patient complaint that we have had with the teleservice.
Yeah,
the
that's
night service.
that's
I mean,
that's
and, and
spectacular.
and I'm telling you, as an administrator that deals with that unfortunately has to deal with the complaints, sometimes no news is good news, right? sometimes
Right.
Yep.
sometimes that speaks for itself. And in regards to the providers at the clinic, that's what I would say as well. I know just the nature of how things work, that the clinic providers, the primary care providers, the 8 to 5 docs over there don't really have a whole lot of interaction with the teleservice, but I have heard no negative feedback whatsoever in the 5 years. And these are people that they're gonna review H&Ps, right? So when a patient gets admitted, they're probably gonna go back and look at that initial H&P. I've gotten no negative feedback or untoward feedback whatsoever in the years that we've been doing this. So I take that as a win. I take that as good news.
Yeah, and Dr. Sturgell, I ran some numbers yesterday when we chatted, and we've managed well over 1,000 admissions at Barton County now.
Yeah, that's
incredible.
That's an unbelievable number.
It is.
In a rural hospital, and again, Chris and I got into the weeds on the metrics and the details and what the numbers look like today versus 2018. They're dramatically different. So it's amazing things that Cox Barton County is doing. It's really impressive, and we're very fortunate to be a part of a phenomenal team in Cox Barton County. So Dr. Sturgell, with your experience with the program and what you've seen over the last 5 years that has occurred through the program, and as Andy just mentioned, over 1,000 admissions by the Telehospitalist team, what do you think? You have at the end of the day, when it comes to physician champions, sometimes it's hard for a physician to take that leap of faith and put their neck out on the line and put that much skin in the game based on where your hospital was and in the distress that it was in, to take this significant fundamental change and lead that out. What would you have to say to that provider in that situation? What would you have to say to that president of medical staff X that needs to take that on? And the follow-up part of that question is, do you feel like these types of programs can benefit rural hospitals in general and can improve the bottom line and can improve the financial status of the hospital?
So I not only think that, I think that that's the way. I think that that's the future of rural healthcare. I really do, and it's been proved, right? So it's just in our 5 years. So how long have you guys been doing this?
10 years.
Yeah. So we've been with you for half of that journey. So
right.
I think that this has been vetted. This has been proved. And one of the things I wanted to dovetail back on is when we started our stroke program, we implemented telestroke as well. And our experience with your service was one of the things that we used as a proof of concept. Like, hey, we've done this and this works. This works for the inpatient. So there's no reason that we can't implement this for stroke. And I'll tell you that we did not have all the fear and the trepidation, the naysaying when we implemented that program as we did when we implemented the initial teleservice, because it had been vetted, it had been proved. Everyone knew that it worked.
Right. And on the stroke neuro programs, right now, back to your point on the stroke programs, right now in our stroke programs, we're seeing a 73% retention rate across all neurostroke patients hitting the emergency department, which the data in a lot of our rural hospitals where we implement those programs is seeing a retention rate of about less than 10%. So it's a significant impact.
That's incredible.
And
absolutely incredible.
It's an insignificant impact on the admission strategy, but it also impacts the ED. And again, the outmigration data and ED perception in the community, you go back to part one and listen to that. Chris and I had a pretty robust discussion on that in part one. But those are significant numbers when you start combining and stacking multiple programs that can be brought to the rural hospital. If you add things like pulmonary and nephrology, infectious disease, et cetera, it really starts to maximize the programmatic offering.
Yep.
Well, just having in regards to the program and the people we call at night, just having a service where they know the mission is to keep patients local, right? They know the mission is to keep patients local. They may not be directing the day-to-day care, but they have a very important role in gatekeeping those patients and getting the initial order started and preparing the way for the daytime team to come in and take over the excellent care of those patients. And that's been a struggle in the past in medicine, right? So if you have somebody that's on 24/7 or that's taking a night call that's not too excited about it, you start to, this is just human nature, you start to get a little bit of an authority gradient. You start to maybe, you maybe get an ER doctor like, well, I got this patient on the fence that could go home, could come in, probably prefer him to come in, but such and such is on tonight, and I don't really want to get in a fight.
You're right.
Let's just
Yeah. That doesn't happen.
Listen, this may be not PC to say, and this may be a dirty secret we're airing on this podcast, but it happens in every hospital in the country,
Right.
But having people that you call that that's what they do. They're on nights, they're awake, they're up, they're taking admissions, they're engaged. They're on the same page in regards to keeping patients. They trust us, we trust them, that we know to triage what can stay and what can't, and that leads to retention. That leads to us being able to keep more of those patients locally, which is what we want to do.
Yeah.
Yep.
And real quick, to circle back on one more point you brought up about how you brought on the daytime hospitalist coverage as part of the program to help augment the overall program. It's a very solid model. We have several different models, but this is one of the better ones that we prefer to do. That being said, and your point on recruitment, we have really proven out over the years that these programs really have a dramatic impact on the ability to recruit providers to your community, and really across all the subsets. It's whether it's surgeons, for example, that are more reluctant to do surgeries on site for whatever reason if you don't have these certain specialties available or coverage available. And your daytime hospitalist, you pointed out we've had several hospitals where we've put in telehospitalist programs that have had 4 or 5 providers, and it's failed, been extremely expensive to do, and it just hasn't proven the benefit that it could have. But the daytime hospitalist, it's so helpful. What we've seen in many instances, so helpful to offer the physician, hey, come work at Cox Barton County. And by the way, we have this strong telehospitalist program, the strong stroke neuro program. We have these services that are available to support and augment you, and you won't be getting calls at night, to take care of these patients, right? And unfortunately, the day at age said, well, you just come be the gal or the guy, and don't worry, you're only going to be on 7 days a month, but we won't call you those other days. And of course, we all know how that goes. So can you maybe just shed some light on your experience with the recruitment, and maybe Chris, you can augment that too. But what have you seen? Have you seen as an easier sell potentially with those services in place?
Yeah, even here recently, we have new grads that come out. As Dr. Sturgell was saying, it becomes so challenging to get a physician that wants to do the entire gambit. But whenever they know that they have that support of the physicians at the night through the telehospital service, we have a new physician now that wants to do clinic work. He wants to do the hospitalist work because he knows he's not going to be getting called in the middle of the night. It just makes it so much easier for those physicians that do want to say, I only want to practice clinic, or I only want to do hospitalist, or I want to do the combination of both, because we can offer that variety there. And then I also say, just that ability to know that you don't have to send your patients out to your competitors. That's the biggest challenge we run into in rural America, is that you send them to a tertiary medical center. They do what they're supposed to. They get the specialists, and then they start hitting all these other primary care visits. Then you've lost the patient forever. With telehospitalists, you can keep those locally. And it's really helped us recruit those physicians, because they know if I built that relationship with the patient, I'm not going to lose them to the bigger city an hour away.
Right. Absolutely.
Right. Yeah, I think, and I'll speak to the emergency department, kind of a topic that we just touched on, but the burnout factor, right? So if I'm if I'm making calls at night and I've got somebody that's rough and I feel like that I need to get in a fight or an argument to admit a patient or get the patient where I think they need to go, man, just day in and day out of that erodes your will to practice medicine. And so I think that's probably an underappreciated aspect of all this as well. I know my guys know that when the night comes and they have an admission, I mean, it's they're not going to have any problems or any stress about it. It's going to be a nice, smooth process. They're not going to get any pushback, and it's going to be a very professional, collegial interaction the way it should be.
Yeah, excellent. Excellent. I can't agree more. The recruitment's one thing, and the burnout, as you mentioned, is another major factor. Recruiting ED providers isn't the easiest thing in the world to do. I mean, it's tough to recruit any providers, right? Really, even in the urban markets, but rural is exceptionally more difficult, and then ED on top of it. So, well, I guess, Sandy, anything else you'd like to add at this point?
I think the partnership with Cox Barton County has been really incredible. Dr. Sturgell mentioned their local mission is really to keep as many patients there as they can, and that just dovetails right with the mission that we have, is to keep patients local whenever possible, whether it's hospitalist or stroke or acute pulmonary or any of those other specialties.
Right, and it's funny you bring that up. I can't agree more. I was asked this question. In fact, Chris, I was asked this question down at the Missouri Hospital Association, talking with a couple of the other speakers, and they one of the question was essentially posed: why do you think that these programs have been so successful over the years? What's in your secret sauce that makes these programs really fly? I said, it's really not us. I mean, we have an amazing team, and it's well oiled, and there's been, I can't even count how many billion hours been put into these things. But at the end of the day, where the rubber meets the road, it's all on our rural facility partners. It's on the administrations. It's on the Chris's of the world. It's on the Dr. Sturgells of the world that really make this happen and support it. And then it's on the nursing staffs in those communities. And this is a partnership, right? This isn't we're not a vendor. It's a partnership. And the only way these programs work is to have mutual buy-in and mutual alignment on the direction you want to take these programs. And I got to tell you, without support of folks like Dr. Sturgell and Chris Wyatt and their teams and their ongoing involvement in perpetuating the fundamental necessary changes that are coming down the line and supporting that, it's tough to work. It's a tough proposition to make these things work, because, as I mentioned, when you're going into the start with Dr. Sturgell, and then the other 90% of the med staff is either ambivalent or has so much anxiety, in some cases completely opposed, and in many cases nursing staff can be in that same boat. So, boy, it's so helpful to have those champions that stay the course, and of course, obviously, the performance out of the gate is helpful too. But really, it's the amazing work being done in rural America. It's the amazing work being done in our rural hospitals. The rural hospitals, in many cases, the quality of care is in many cases better than they would get in the tertiary centers anyway. The patients want to stay there. It's a less expensive environment. They don't have to deal with transfers and the costs associated with that. The family burdens of having to go stay in hotels and missing work when they can stay at home, close to home, in their community hospital, which is beneficial for the hospital, and it's beneficial for the community and ultimately helps sustain rural health. So I cannot say enough about the Chris Wyatts of the world and the Dr. Sturgells of the world, who grew up in rural America and are fighting for rural America and are fighting for rural hospitals and their patients in rural hospitals. And I just can't thank you, Dr. Sturgell and Chris Wyatt, enough for the amazing work you guys do every day down in Cox Barton County.
Well, much appreciated. You hit the nail on the head. It is a partnership, and getting your ego aside and saying that we need some help and that a rising tide lifts all ships. There's enough to go around in healthcare that put some things in the experts' hands. Let's not try to do everything and try to, even if you're part of a system. Too often we try to think that we can do everything internally. We're just not efficient because we have so many things we have to do. So
Right.
that partnership with you has made it so much easier. And that's why we have even looked at expanding your services throughout the entire system. We were the blueprint to show, all right, can it be done in rural America? And that was before we were even integrated within a larger system. And we proved it could be done. And then the integration came, and then it made it even easier. So thank you for that.
Our pleasure. Yeah,
Absolutely.
Again, it's been fantastic, and it's humbling to know that we've been a part of taking care of over 1,000 patients, inpatients, and admissions. Actually, 1,000 admissions into your facility and county, and we're just elated to continue to be partners.
Yeah, I echo what Chris said. I think one of the highest compliments that your service can get in our community is when someone comes to me, and because people come to me all the time in the community. Such and such was in the hospital, and I may not have in my mind who's on that week in terms of our service. Like, okay, well, who's the doctor? And they'll say, well, it's Dr. Schweitzer. It's like, oh, well, that's and that to me, that's just the highest compliment, that they remember that interaction, and they thought so highly of that provider that they saw them as their physician for their visit. So
yeah,
it warms my heart when I hear that. And I tell you, over the years, we have gotten very close with some of the providers. There seems to be a core group of providers that we work with, and we get close with them. I mean, we if we've got a couple minutes on the phone, how the kid's doing. I mean, it becomes a real relationship, and I do feel like they become part of this family, and we're very, very thankful for that.
Right, sir. One of our two first hospitalists ever hired 10 years ago was Dr. Schweitzer. So she's amazing, and you kind of hit the nail on the head, Dr. Sturgell, that anymore it's almost not a telehospitalist program. It's just hospitalist program. It's part of care. It's part of what people expect, and I got to tell you, if it's in a high quality way and they can stay at home and close to home in a high quality way, their patients are all in.
Absolutely.
They're just all in. So again, can't thank you both enough for taking time to spend with us again today. You, Chris, for the second go around. So really appreciate your time. And Dr. Sturgell, I know you're busy as all get out. Always appreciate to chat with you and then to have you on our podcast. Can't thank you enough. As I mentioned before, don't forget, if you haven't listened to part one, please do so. It was a phenomenal take from Chris from a CEO perspective on these types of programs. Very insightful. So I encourage you to go back and download and listen to that episode as well. Other than that, Andy, I think we're good to go here.
Yep, I think we're good. Thank you, Chris, Dr. Sturgell. It's been a great conversation, and we look forward to talking again some other time.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledymehealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledymehealth.com.